Okay, if you are ready, we can go ahead and start. We have 21 people,
Hey,
and I'm pretty sure uh,
sounds good.
other actually participants will join us shortly.
Okay, great. Well, thank you everybody for being here. Happy Nowruz to some people on the call. Thank you so much, Soroush. It was I'm so grateful to have learned that part of your culture tonight. So thank you for sharing that with me.
Thank you.
Um, Yeah, so welcome. I'm here to talk about syphilis. My name is Vanessa Poliquin. I think that I've worked with some of you, perhaps we've been in other talks together, but I am one of the OBGYNs who works out of health sciences, and I also have a bit of extra training in infectious diseases. So that's why I'm usually pretty happy to come and talk about ID topics. So please interrupt me at any time. I'm not the bad. I'll try to monitor the chat, but in case I miss something in the chat, just feel free to shout things out. Um, this is the traditional territories acknowledgement of, it's actually an old version. I'm sorry, I did not update with the newest version of the University of Manitoba Land and Territories Acknowledgement. But I am a visitor on Treaty 1 territory, and I'm originally from Toronto, which is the traditional territory of the Mississaugas of the Credit. And I, gain a livelihood and have raised my family on Treaty 1 territory. Our water comes from Treaty 3 territory and our energy from Treaty 5. And my commitment is to, learn every day and reflect on how our colonial history and systemic racism has shaped the current state of where things are at and the disparities in health that we see, and to continue to learn and listen to understand how we can build small acts towards reconciliation into our everyday practice. I'm hoping that by the end of this session, you'll be able to describe the changing epidemiology of syphilis and Canada and syphilis in Canada and recognize that Manitoba is kind of the leading edge of that epidemiologic trend. And the whole point of this, though, is really to make it not theoretical, but very usable for you. So I'm hoping that we're going to work through some cases tonight so that when you leave this session, you're able to, even use e-chart differently to really help you with diagnosis of management of syphilis in pregnancy. I'm also hoping that we are able to recognize different patterns when it comes to interpretation of syphilis serologies and recognize the importance of pairing serologic tests with treatment. So this is the type of case that we're going to work throughout the course of the presentation. So I'll give you a stem, and notably for I think most of the cases, the stem is going to look remarkably similar. But how the case evolves might change. So this is the case of a 21-year-old female, and she's presented at 18 weeks gestation to your prenatal clinic or to your family practice clinic, and you receive a result. So something that I like to do in clinic with trainees, especially if we're waiting for patients to get there, is I usually find a syphilis result in my pile, and I say, here you go, CMIA positive, RPR is 1 in 8. How do you interpret this? So how do you interpret this patient's serology, and how do you manage this patient in the antepartum period? And I realized that my animations are not working very well because I'm giving you the answer right away. But the reality is that from one result, we can't say if this is primary syphilis or secondary syphilis or late latent syphilis. We need to have more information. And we're fortunate in a way in Manitoba that we have the ability to have all of our STBBI results, as well now as the majority of our treatment history centralized onto eChart. And I think that's a really powerful tool. that we have to harness here in Manitoba. So syphilis, I like looking up retro posters of syphilis. It's pretty impressive, actually, that this disease has been around for so long, and I guess miraculously, in a way, or inexplicably, has never really developed resistance, and we continue to be able to use the same antimicrobials as we've used really for decades. And what's perhaps more unbelievable is that despite the fact that we have highly effective, fairly basic antimicrobial therapy that treats this, we continue to see epidemics of syphilis. And this quote by Coleman and Dobson, I think, really speaks to that. When a disease approaches eradication, it's often the control program rather than the disease that's eradicated. And I think that that was what we're seeing here, is that syphilis was almost off the radar for a while, and that meant that a lot of public health measures to control syphilis were relaxed, and we've experienced a resurgence. And what's really catalyzed that resurgence is a bit of a syndemic of substance use, STBBIs, as well, which has allowed syphilis as well as other STBBIs to increase and rise in prevalence. So I haven't included a lot of epi data on here, but this is just a graph to demonstrate that, oh, I don't even have an x-axis, I'm sorry, but the x-axis is 2005 to 2014. And what we see is that over the past really decade and a half, there's been a rise in reported rates of infectious syphilis. And most notably, the rise has been in the reproductive age groups, most notably between 20 and 39. And if we broke this down by sex, we would see that the distribution of syphilis across the sexes used to be very disparate, with rates among men, particularly men who had sex with men, being very high, and those among women, particularly heterosexual women, were low. And now we're seeing rates of men and women being the same. So we're seeing an increased burden of infectious syphilis among women of reproductive age, which is where our concern for congenital syphilis comes into play. There are other graphs that we could look at, which do provide a little bit of a glimmer of hope. For the first time last year, we finally started to see some flattening of our rate of rise for infectious syphilis. And this past year, for the first year, we've been able to report fewer cases of congenital syphilis than the year before. So we are one of the only jurisdictions in Canada that are starting to hopefully come over that peak. But certainly we're far from being able to say that we have things under control, and need to continue to make positive changes that we've been seeing over the past 5 years. So the natural history of syphilis, we read about it in textbooks, and we've been seeing it more and more in real time. The classic kind of first lesion is a chancre, and we think of it as a painless chancre that resolves in 3 to 6 weeks. The challenge is that sometimes they're not painless. Sometimes there's an infection in the area that actually creates some discomfort for the patient. And sometimes we actually don't see the ulcer at all, because the ulcer is happening within the vaginal canal and not necessarily on the vulva. So it's not uncommon that we never see a primary chancre. That's that classic painless chancre, especially in women. So what we oftentimes will see more in terms of an overt presentation in our female population is secondary syphilis. And here I've got some dermatologic findings. So sometimes you can get lymphadenopathy or a diffuse rash over the trunk, or sometimes on the palms and soles. The other thing that we see very commonly in gynecologic practice is genital lesions, so condyloma lata. And sometimes these can be painful, again, because they're surrounded by a superinfection or cellulitis. Then what we see once that secondary syphilis resolves is latency. And latency is really when the pathogen is going silent, the spirochete has migrated intracellularly and is not causing a lot of inflammation or overt sequelae. And the main definition of early and latent syphilis just has to do with how long it's been since the infection's been acquired. And arbitrarily, there's a line that's drawn at 12 months. If it's been present for less than 12 months, we define it as early syphilis. And if it's been present for more than 12 months, we define that as late syphilis or late latent syphilis. And the main distinguishing feature is that we need to treat late latent syphilis with more doses of bacillin than for early latent. And the reason why we want to get on top of this is because if we miss the opportunity to treat primary, secondary, early, or late latent syphilis, it can progress into tertiary syphilis, which can have a variety of different pathologic features depending on where the spirochetes have settled and proliferate the most. But certainly, if we look at the history books, we can see implications for organs like liver, heart, brain. We can see disfiguration and deformation of bone. And certainly we can see neurosyphilis. Neurosyphilis is a bit unique compared to other forms of tertiary syphilis because neurosyphilis can present late, many decades after natural infection, like tertiary syphilis. There are other forms of neurosyphilis that can present quite early and in fact are within the first year of disease course. So Kathy, there is no easy way clinically, like looking at a patient to determine if it's early or late, but there is a good way when we look at lab results. And I'm going to go through with you how to set up your E-chart so you can determine whether it's early or late. And it all has to do with when their last negative test was, how long has it been that they've had syphilis. So we'll go through that in a second. So why congenital syphilis matters to us. We've talked about why tertiary syphilis matters. There can be some important sequelae for adults. Congenital syphilis matters to us because there can be some important sequelae for infants. Some of those sequelae might be seen at birth and some might manifest later if the syphilis is not diagnosed and treated. So we have seen stillbirth and neonatal death from syphilis. In fact, we've done a recent case review of all stillbirths at HSC, and we've identified that during kind of the peri-pandemic period, so from about 2017 to about 2023, we reviewed all cases of stillbirth, and we identified that at HSC, our provincial obstetrical hospital, about 1 in 10 stillbirths might be syphilis related. So we have not been able to prove that the stillbirth was caused by syphilis, but we have demonstrated that of all the stillbirths, syphilis seems to be a factor, which is a pretty important number, that 1 in 10 stillbirths might be syphilis related in our province. It can lead to bony deformities for the infant, anemia, organomegaly, jaundice, and have long-lasting nerve or brain sequelae, including meningitis and disfiguration. And again, some of these might be overt and present at birth. Some may develop over the first years of life if the syphilis is not diagnosed and treated. So how common or how risky is transmission of syphilis? It depends on the clinical stage of the disease. It's interesting to read about syphilis clinically because a lot of what we know actually comes from very old texts. And so there's this old law called Kasowitz's law, which really is described as a story in some of our textbooks, a story of a woman who had syphilis and who had 5 consecutive pregnancies. In her first pregnancy, presumably shortly after her sexual debut, and perhaps shortly after she was infected with syphilis, she had an infant that was stillborn with stigmata of congenital syphilis. In her next pregnancy, so presumably a little bit further along her natural progression of disease, this is in a pre-antibiotic era, her pregnancy progressed to full term, but again, the infant was born with congenital syphilis stigmata. She went on to have triplets, of which 2 out of 3 had congenital syphilis, twins, where now only 50% of her offspring had congenital syphilis, and finally, after multiple pregnancies, presumably when she was in the late latent phase of her illness, she finally had a healthy term infant. And I don't know if that story that's described in this case report in the textbook is true, but it's just to illustrate that earlier in the disease course, there's a high risk of transmission to the infant, a high risk of congenital syphilis. If somebody has late latent untreated syphilis, there is still a risk. It is less. It doesn't mean that we shouldn't treat it, but it is less of a risk to the pregnancy than in the earlier first, second, or early latent stages of syphilis. How do we diagnose syphilis? Well, it kind of depends on whether you're seeing a primary lesion or whether no lesion is present. So if you're seeing a primary lesion, then you have the opportunity to take a swab of the lesion. You can send it on a flocked swab using your universal transport medium or your viral medium. And if you don't have a lesion present, you're relying on serology or a blood test. So I copied this. This is a memo from Chatham Provincial Lab. I guess 2023 is when they changed their policy so that when you send a swab in viral medium now, if you request any of HSV, syphilis, or VZV, it just gets run for all of the mucocutaneous lesion pathogens. So if you send it for HSV, you say there's a vulvar lesion or a penile lesion, they'll send it for syphilis, HSV, VZV. On the requisition, you can write lesion panel, you can write syphilis PCR, you can write HSV or VZ PCR, all of the 3 pathogens, HSV, VZV, and treponema pallidum will be tested using nucleic acid amplification. So that's kind of handy now, and it's helping to diagnose more cases of syphilis that may have previously been misidentified as HSV or VZV and vice versa.
Sorry, Dr. Poliquin,
Yeah.
how we can get this swab, this type of swab?
You would just use it like a viral swab. So do you guys have access to the swab that you would have used to like send like a respiratory virus swab, like a nasal pharyngeal swab?
Yeah.
You can send it in that.
Yeah. Okay. Thank you so much. Thank
you. Okay, so when it comes to serology, there's really 2 kind of big groups of serologic tests that we can run. There's the non-treponemal ones and the treponemal ones. So the non-treponemal ones, many of us might remember as being like, we remembered saying, oh, did you send a VDRL? Because back in like 2000, in the 20 teens, I think it changed in about 2013. This used to be the first test. So even on some of our prenatal forms, it asks for the VDRL. We used to send for the non-treponemal test first. The challenge is that there's a lot of false positives when it comes to these non-treponemal tests. If you have another illness that's like an acute viral illness, pregnancy, recent immunizations, or if you have hepatitis C co-infection, malignancies, malaria, a lot of things can make the VDRL go positive. And so we switched from the primary test being non-treponemal to the primary test being treponemal in about 2013. And this is a more robust test for being able to detect earlier stages of the disease, but also has fewer false positives. The challenge is that a treponemal test never goes back to negative. Once you've had syphilis, you're going to be CME positive forever. So there is still a role for the non-treponemal tests, and that's to monitor response to treatment. And we'll talk about that in the coming slides as well. So I put this little symbol up here, VDRL and RPR. There was a time where Manitoba was still using VDRL and other provinces had already moved over to RPR. And so especially seeing patients from Nunavut, we'd have to, switch between systems. This is just to say that VDRL and RPR, they're like American and Canadian currencies. They If you have more American dollars, you probably have more Canadian dollars, but they're not exactly equivalent. So if you're ever seeing somebody that's coming from a different jurisdiction and you're looking at their RPR and you're trying to interpret it from a VDRL, you can't really compare them directly, although the trends should be in the same direction. So this is just to demonstrate again, for anybody that trained in a system that tested for VDRL or RPR first, why we switched to the reverse algorithm in about 2013, 2014. So the reverse algorithm is what we use now. We're testing for that CMIA as a first test rather than your non-treponemal tests. And it's just to show that stage for stage, whether it be primary, secondary, early latent, or late latent, the performance of the reverse algorithm is better. So if you're coming from a place where you used to test for VDRL, RPR, that's why we do it a little bit differently here in Canada. There are many different diagrams that you can find that lead you to the same conclusion. I've put one up here that you're welcome to take a screenshot of, or I can provide my slides. But truthfully, find one algorithm that speaks to you, that you find easy to read, and put it up in your office. And until this became burned in my brain at the beginning of my practice, I had this up in my office and I referred to it. Very commonly. I'm just going to walk you through the algorithm in case you want to use this one. Again, any algorithm that presents it clearly in a way that speaks to you will lead you to the same conclusion. But you start with your CMIA or your treponemal test. Best case scenario, it's non-reactive, it's negative, and you can move on. This person doesn't have syphilis, unless you think they might be in like a window period where they just got infected. If they have ongoing risk of exposure, you might want to test them again in a few weeks. If the CIMA goes positive, that's when you then test for your non-treponemal test. And you'll oftentimes see, and for sure for us, for the first time the treponemal test goes positive, our lab, our CADM lab, runs a second treponemal test called the TPPA to make sure that that was a true test. If your treponemal test and your non-treponemal test are both reactive, then you can conclude that this is an active T. pallidum infection. In some cases, though, you might have, an RPR that goes positive, but your second treponemal test, your TPPA, does not go positive. That's kind of the most unlikely situation, probably in a window period. Repeat everything. In some cases, you're going to get a positive treponemal test. Your confirmatory treponemal test is positive, but your RPR is negative. That's probably an old infection. You're going to want to dig back, make sure that they receive treatment. Versus treponemal test goes positive and both of your follow-up tests are negative. So your second treponemal test and your non-treponemal test are negative. And that is when you have a false positive. Typically, that's when somebody has been exposed to another type of non-treponemal pallidum infection. Sometimes when they've come from other parts of the world, particularly Africa, they might have had exposure to yaws, for instance. So I appreciate that was a lot of information. I'm going to send out my slides. Find yourself an algorithm, put it in your office, and then I suspect for many of you already, this algorithm is really starting to consolidate itself in your brain. So we're going to actually work through a few cases, thinking through that type of an algorithm. You'll notice again that the stem is the same. It's a 24-year-old female, G3P2, 18 weeks, and you're in your office, you're reviewing today's prenatal serology, your CMIA comes back positive, your RPR is 1 in 8. And you've asked for more information because you know that just with an RPR of 1 in 8, you don't know what's going on. So you've dug into eChart. You've gone back to September of 2023. You've identified that at that point in time, that was her last negative test. By May of the next year, so this is less than a year, the CMIA is now reactive. Somewhere along September to May, this person has acquired syphilis, and her RPR is 1 in 64. So the question came up before, how do you know if something's early or late? I know that something's early or late if I can go back in their serologic records and identify that less than a year ago, they were CMIA negative, and that they have therefore converted to be positive within less than a year. That's the only way I know for sure that this is early syphilis, with the exception of actually being able to see a primary lesion. That would be the one clinical indication that this is definitely early syphilis versus something later. For me, I feel most secure looking back at serology and being able to chronologically identify that there's no possible way that somebody's had syphilis for more than 12 months to be able to call it early. So this person has had it for less than 12 months. They're pregnant. You give them 2 doses of, they got 2 doses of bacillin. Then in August, they had demonstrated a drop in their titers, and by March, you're looking at their serology now, and the RPR is 1 in 8, which is down from 1 in 64. So this, my animations are not working again because I've just underscored the answer for you already. But we know that this is early syphilis because we can see their last negative. They definitely acquired syphilis in less than a 12-month period and were treated within that time and have had nice response since then with no rise in their titers. So we know that they have treated early syphilis, or they had treated early syphilis. So I wanted to spend some time showing you how I set up my e-chart so that you can get this beautiful, this table here. If you're digging through results from different places, it's really hard to have all this information consolidated. And so what I like to do is I like to set up my e-chart in a particular way so that I can see all of the syphilis serology in one place and I'm not confused by other results that are unrelated to syphilis. So what I do in my e-chart is I go in, and the first thing that I do is I make sure that I'm looking back as far as I can look. So I'll usually scroll down to, 10, 20 years. You can go back as far as 30, I think. And I make sure that my units are switched to year instead of months. I then use this button here to deselect everything that I don't want to see. So I deselect everything and I expand serology, and I only click my syphilis results so that when I then hit show, I am only seeing my syphilis results, and I'm seeing them date after date after date after date, which allows me to make an assessment about what's happening over time. I will caution you that this show button, it's a very finicky button, and it likes to be clicked on. And sometimes when you click on show a couple of times, it actually keeps showing you more results. So I usually click on show a number of times to make sure I'm seeing the patient's full set of results. And in this setup, I can see really beautifully what's happening over time. So next time you see a syphilis result come through your clinic, I really encourage you to take time to go into eChart, play around with how you can set it up so that you can see the results beautifully in front of you, and it makes interpretation easier. So the question that was asked earlier of, how can you tell if it's early versus late? It's a really important question because the main thing that changes between early and late syphilis is how many doses of bacillin you give. So it is really important to be able to determine whether somebody has had syphilis for less than a year or whether this person might have had syphilis for more than a year. And again, I do that using eChart. If I can see that they've had syphilis for less than a year, I'm confident that it's early. I'm confident that they only need either 1 dose of bacillin if they're not pregnant, or 2 doses of bacillin if they are pregnant. Guidelines will say 1 to 2 doses in pregnancy, and that's because 1 dose in pregnancy should be sufficient to treat syphilis. There are some studies from the 90s that demonstrate that the drop in titers is faster if you give 2 doses, and that's particularly important for trying to determine successive treatment so that babies don't necessarily need treatment after delivery. So I give 2 doses in pregnancy for early syphilis. You would not be wrong if you gave 1 dose. There's certainly other guidelines that say that you could give 1 dose. Manitoba recommendations are 2 doses. This is different than late syphilis, which universally needs 3 doses of IM bacillin spaced 1 week apart. So unless you can look on e-chart and identify that they've had syphilis for less than a year, you're giving them the 3 doses of bacillin. Management in pregnancy is really multidisciplinary, and it requires monitoring, but it also requires some collaboration with other colleagues. So the first thing we want to do is offer prompt treatment. We don't want to delay treatment. We have done some research here in Winnipeg to demonstrate that the risk of something like Jarisch-Hersheimer reaction, which is uterine contractions secondary to treatment of syphilis with bacillin, are very rare. So you can go ahead and treat this in community, even if somebody is early in pregnancy. We're not worried about increased risk of preterm birth. We're much more worried about the risk of not treating syphilis during pregnancy. You'll want to then send monthly titers until delivery, and that's to look for serologic response, but also to monitor for reinfection. So a rise in the RPR would indicate reinfection. You'll want to refer to fetal assessment to make sure there's no evidence of overt congenital syphilis. And you'll want to ensure that you're testing for all STBBIs, because if you've acquired 1 STBBI, it's very possible that through the same route you've acquired another. Consultation with pediatrics and peds infectious disease is important for determination if infant is going to need treatment, and that's usually determined with the dynamics of the serologic change antepartum, but most importantly, the paired titers that are sent at delivery. So both mom and babe get a titer sent at delivery. And something that I don't think we spend enough time talking about is the fact that congenital syphilis is highly transmittable. So we think of syphilis as a sexually transmitted infection. Sometimes it's transmitted through IV drug use. But if a baby truly has congenital syphilis, they themselves their mucocutaneous lining or layers are very infectious to people around them through contact, or sometimes through when fluid or their fluid is acquired through our mucous membranes. So if you are delivering somebody where we're concerned about congenital syphilis, gloves, as always, eye protection, and awareness of wearing gloves when you're handling the baby as well until congenital syphilis is ruled out. A little piece of historical knowledge is that I think we've all heard of Semmelweis. So Semmelweis was a obstetrician in Vienna in the 19th century, really critical person for identifying the need to, use hand washing to prevent puerperal fever. And he actually died a really awful death. And it is thought that his mental health deteriorated throughout his life, potentially because of neurosyphilis. And neurosyphilis syphilis and neurosyphilis was kind of a common work hazard among obstetricians in the 19th century, because we didn't have any way of protecting ourselves or treating syphilis, and we were oftentimes in contact with infectious material as well as infants with congenital syphilis. So historically, syphilis was a work hazard for obstetricians, and it can still be a work hazard today, so please wear appropriate PPE. So I oftentimes get phone calls from physicians who are concerned that the titer, the absolute value of a titer, still appears to be really high. And so I do spend a little bit of time talking about how it's the absolute value of the titer is not as important as the dynamic change in the titer. So somebody might have a titer before delivery of 1 in 32. And I actually might be pretty happy about that, because if I look back, their titer 3 months ago before treatment was actually 1 in 256. So I'm not really fussed about the 1 in 32 titer. That's telling me they've had a beautiful response, and there's no sign of reinfection. That being said, I might see a titer of 1 in 8, and I look back and their last titer was 1 in 2. And then I'm much more excited about the titer of 1 in 8. So for me, it's not the absolute value of the titer, not for me, for everybody, it's not the absolute value of the titer that's as important as the dynamics. And if the titer is not super low before delivery, but it's much, much lower than before treatment, and it's trending in the right direction, that is reassuring, even if the titer is still on its way down. So we're going to do another case now. Again, 24-year-old G3P2 at 18 weeks. You're checking serology today, and the RPR is 1 in 8. You dig through eChart, you set it up so you can see all the results, and you find that there's been no results since January of 2022. At that point in time, the CMIA was non-reactive. So that looks like her last negative was over 3 years ago. By March 19th, by today, her CMIA is reactive with an RPR of 1 in 8. So what does that represent? So that represents late latent syphilis, because here again, what the serology is telling me is that there's no way that I can guarantee that this person has acquired syphilis within the past year. It could have been anywhere from January of 2022 to January of 2025. And so I have to assume that this is late latent syphilis. And because I'm assuming it's late latent syphilis, I'm giving this person 3 doses of bacillin. The recommended treatment for late latent, as we said, is 3 doses of bacillin. And I think that my next slide talks about, my next slide talks about how bacillin is the only approved treatment during pregnancy. So there are other therapies for syphilis outside of pregnancy, doxycycline being one of them. But the reason why we have not moved over to using anything but bacillin in pregnancy is because all of our data really demonstrates that bacillin is effective, and we don't have data that's robust to demonstrate that other therapies are robust in pregnancy. We're well aware of the pharmacokinetics of bacillin. We know that it gets into the placental circulation. We know that it gets into the fetal compartment. And that's why it's really important for us to use bacillin during pregnancy, even if somebody has a reported allergy to penicillin. We have a penicillin delabeling clinic for pregnant patients at HSC in Winnipeg. Dr. Barber is the allergist. He's very welcome to take phone calls. He's happy to help. But 90% of people who report a penicillin allergy are in fact non-allergic. So we have a way of expediting patients into penicillin testing during pregnancy to see if they fit into that 90%. If they're the 90% that are non-allergic, then we can go ahead and treat their syphilis with penicillin or with bacillin. If they are allergic, we also have a desensitization protocol at HSC Women's where we can help to desensitize someone to their penicillin allergy. So we can go ahead and treat them with bacillin following desensitization. So the take-home point here is that bacillin is the only treatment for syphilis in pregnancy. If somebody has a penicillin allergy, we still have to give them bacillin. So either we test them and determine that they're non-allergic, or we test them, find out that they are allergic, and then we desensitize them. And to do all of this, there's a clinic that can expedite this through HSC Women's, and you're welcome to refer to that clinic. So another case here, again, 24-year-old G3P2 at 18 weeks. Serology today shows a CMIA positive and an RPR of 1 in 8. You set up your E-chart, you take a look back, and you see that in May of last year, she was negative. Okay, so you know it's been less than a year since her last negative test. Then by November, she was now reactive with an RPR of 1 and 2. So somewhere between May and November of last year, this person got syphilis. You're very excited. You've diagnosed syphilis. You know that she needs like 1 to 2 doses of bacillin. She doesn't need 3 because we know that this is not late latent. You ask her to come back into clinic and she no-shows on December the 1st. She comes back on January the 14th and you're so excited to see her that you give her treatment. And then you repeat her serologies 2 months later and you're scratching your head because you're like, I treated her, but her RPR is 1 and 4. So what the heck happened? Is this treatment failure? Is this a new infection? Is this early syphilis that's treated? Is this neurosyphilis? It's kind of hard to say, to be honest, because we don't really know what really was happening on December the 1st or January the 14th. We don't know if this went down and then came back up, or if this went up in that time or came back down. And so this is kind of a bit of a graphical representation of what I oftentimes see is that people send me patients and say, we don't know what happened. The RPR went up after treatment. And when I look back and look at when the treatment happened and when the results are from, I oftentimes see that treatment was given appropriately, but at the time of treatment, especially if there's been a delay getting someone back into care, there was no serology that was sent. And we've got to remember that within somebody's body, serology is doing all sorts of dynamic things. So while this person didn't show up for their appointment or couldn't get to their appointment, we don't really know what was happening with their serology. But if this was an early infection, it's very possible that the serology, the titers continued to rise. And in fact, when treatment was given, the titer may have been very high. And so the 1 and 4 still represents a drop, but we just don't know a drop from where. So the take-home point from this case is if there's been any delay in getting somebody in for treatment, it's really a good idea. Even if it's been just a week, it's a good idea to send a titer, a syphilis titer, that day that you give treatment, so you're well aware of what the peak titer was, and it'll help your interpretation of follow-up results. Okay, I think this might be our last case. The stem is a little bit different. 24-year-old female, G3P2, 18 weeks, CMA is positive, the RPR is non-reactive. Oh, 1 second, checking the chat. So Kathy, I'm just going to go back to this slide. Yes, in this case, I think that you would do some discussion with the patient and have shared decision making. You'd want to understand a little bit more about what was happening in this person's life. But if I had any concerns that there were ongoing risk factors, and it's a total black box as to what was happening in that time, I would explain to the patient why I feel like it's important for us to treat again, and I would get their permission to restart the treatment and have a serologic test on the day that I give the treatment. It's very possible that you won't see the 1 and 4 come down very much, especially if you missed the peak titer and this isn't a reinfection, but at least then you'll be very confident that you have treated it, even if it may have been a new infection. So it's a tough call, but yes, I would treat it and have a discussion with the patient. I'd probably, in fact, draw this picture. I draw this picture oftentimes in my office to explain why repeat treatment is sometimes needed. Okay. Okay, so this patient, RPR is non-reactive. Let's walk through this one. You make sure that you're looking back on your E-chart many, many years, and you see that on January the 1st, the patient had her last negative syphilis serology. By May of that same year, so less than 12 months, the CMA is now reactive, RPR is 1 in 16. So you know that this is an early syphilis infection at that time and seems to be appropriately treated with 2.4 million units of bacillin. And somebody sent follow-up titers, and by 6 months later, I guess 4 to 6 months later, beautiful response, 1 DIL. By April of 2023, non-reactive, and by March during this pregnancy, non-reactive. So this is telling me that somebody had appropriately treated syphilis, and there's been ongoing tests to demonstrate no rise in RPR. So this is a past infection with no evidence of reinfection. As opposed to this patient who has an RPR of 1 in 32, and when you dig back, similar story. So January of 2022, non-reactive, that was the last negative test. By fall of the same year, reactive, RPR of 1 in 64. You know it's less than 12 months since the last negative. It's definitely early syphilis. You treat them appropriately, 2.4 million units of bacillin. And there's follow-up titers to demonstrate a progression down. So by December, down to 1 in 8. By April, down to 1 in 2. No testing for a couple of years, and now back for prenatal care, now with a reactive titer of 1 in 32. So in this case, what we're seeing is a rise from baseline, where the titer settled after treatment, and the rise is greater than 1 in 4, fourfold. So this represents a reinfection, and a reinfection that happened somewhere between April of 2023 and March of 2025. So that's more than 12 months. So you don't really know when in that 12-month period the reinfection happened. So you don't really know if it's early versus late syphilis in this case. So how you're going to identify a new infection, you're looking for a 4-fold rise in RPR. And reading the serologic results was very confusing to me before I got to spend some time in the lab during my fellowship. And so here I have a picture of what the testing looks like in the lab. And basically, those little circles on that card are called wells. And you are sequentially putting more and more dilute specimen from an individual in each sequential well, and you add in a reagent which causes clumping if the antigen is present. And eventually the clumping will stop because the dilution is so much. So the more dilutions you need to do to make the clumping stop, the more antigen there is in the original sample. And so if you see, 1 in 2 dilution, that means that they didn't have to dilute very much until the clumping went away. If you see 1 in 256 dilutions, that means that they had to do a lot of sequential dilutions before they could get the clumping to go away or make the antigen kind of disappear in that sample. And so when you're looking for a 4-fold rise, you're basically looking for a change of at least 2 wells or 2 tubes. And I have like a little mathematical equation here, but I usually just do it in my head by going up by 2 to the power of whatever. So, 1 in 2 would go up to 1 in 4, would go up to 1 in 8. So a 4-fold rise from 1 in 4, for instance, would be going from 1 in 4 to 1 in 8 to 1 in 16. Or a 4-fold rise from 1 in 16 would be going through 1 in 64 to 1 in 128. Sorry, I think there was a question up here. I know this is a complicated part. Yes, Samina, once the CMA goes positive, the RPR is the only way to follow up. The CMA will always be positive for the rest of that person's life, for all intents and purposes. Unfortunately, it doesn't give them immunity, and I usually explain that in clinic as well. It's always going to be positive, but it doesn't make you immune. It's not like the chicken pox. So we're kind of wrapping up in terms of the slides here. So we'll have lots of time for questions, but the take-home point is that you can never interpret a serology result just based on one report. So it's really important to look at the full context of prior history of serology as well as prior history of treatment. Fortunately, those are all available on eChart, and so hopefully setting it up the way I showed you today will help make interpretation a bit speedier. If you're treating somebody, please send a serology at the time that you offer them treatment to make sure you're really capturing that peak titer. If you have antepartum syphilis, you're going to want to follow up with monthly titers to look for any signs of reinfection. You're going to want to make sure that pediatrics or pediatric ID is involved in management planning for the infant so that they can interpret the paired serology and determine if the infant needs treatment. If an infant does need treatment for syphilis at birth, then they need IV penicillin, and they're usually admitted for 7 to 14 days. And please don't ever hesitate to phone a friend. I am available by Tiger Connect. I'm available through paging, and I'm really happy to help. If you send me like a FIN number, I can sit down with you over the phone. We can look at the same eChart set up together, and we can work through a case remotely, which I've found to be really helpful for physicians that are working outside of Winnipeg. So I think that those are all the slides that I have. I know that was a bit of a whirlwind, but here's a question. Okay, Nardin, I would be happy to connect about the case that you have, and I'm in clinic tomorrow morning. So if you are on, I'm just going to check if you're on Tiger Connect, and then we can connect tomorrow about your case. So penicillin, Simranjeep, sorry, I'm just going to send Nardin a message. Hi. So we'll connect tomorrow, Nardin. Simranjeep, so it's not really a one-step process, but we do it in one sitting. So basically the patient, once it's determined that they in fact do need desensitization, they'll come to Women's Hospital. It's actually a procedure that's done in the post-anesthesia unit. So in our OR, they're not having any surgery, but that's where our resources are in case they needed like support for respiratory if they had an anaphylactic reaction. And they're basically given sequentially less dilute doses of penicillin according to a protocol that our allergists developed to the point where they can receive a full dose. And then they would receive that dose and they can go on to have their next dose, and they don't need desensitization again against the second dose. In some cases, I suppose there might be concern for ongoing allergy, but that's not the routine. I have to say that we don't have to do this very much. I can think of about 1 or 2 cases a year because the vast majority of people that report a penicillin allergy are not in fact allergic when we do their testing. I don't know if desensitization is available in Thompson. Based on the complexity of setting up the algorithm in Winnipeg, I'm going to venture the guess and say probably not. Perhaps Dr. Arjwan Mustafa, who's OB out there, might know. If not, you're welcome to refer in to Winnipeg, but it does mean, yes, that the patient would have to travel. Okay, so Kathy, you're asking so many good questions. If there has never been syphilis testing and the first test was positive with an RPR of 1 and 2, so in that case, I would classify that as late latent, and I would treat it as late latent syphilis because you don't really know when they got the infection if they don't have a previous negative test. Okay, so yeah, I'll hang around here for a few minutes if you have any other questions. But I just wanted to thank everybody again for making
Sorry,
time.
Dr. Poliquin, I have a
Yes.
question.
Yes.
Yeah. So I put the question before too, but I think you missed that. That if I have a patient, new immigrant, was tested at the time of immigration and he was positive, not symptomatic, doesn't remember any previous testing, but I think Kathy's answers the question. So does he need follow-ups or how frequent, if he has no symptoms or anything, need to be followed up for
Yeah,
him?
so typically, and you know what, I might copy and paste the URL and put it in the chat. There is the Manitoba Syphilis protocol that has beautiful tables on when you should follow up. And after late latent treatment, you would be following up at 3, 6, and 12 months, and then 24 months as well, just to make sure that there has been some response in their titers, and that they remain suppressed. The other thing that we do see in newcomers to Canada sometimes is on that algorithm where I showed you, like, oh, the CMA goes positive, but then they do the confirmatory test and it's negative, and the RPR is negative. In those cases, probably somebody has had a different type of infection. So a non-treponemal pallidum infection, and that's a false positive, and then they don't need treatment. And if you have any questions about that, you're welcome to Tiger Connect with me and we can go through those results. But in the case of a true positive, then yes, they need treatment, and then you would follow up with them as tertiary syphilis. And I'm going to quickly find you guys the URL. It's a really great resource. I think we actually have the best manual of the country. To be honest, I find it the most usable. Okay, so that's our protocol, right? And Soroush, if you'd like, I can also make the PDF of the slides and I can send them out to you as well.
It would be great, much appreciated. And as always, great session. I enjoyed the game. Thank you.
Okay, well, thanks everybody, and have a good new rose, right? New rose?
No rules, yeah.
No ruse, no ruse. Okay, take
Thank
care.
you so very much. Have a good night.
Thanks. Bye now.
Take care. Thank you. Bye.